Hello, everyone. Thank you for joining. We are going to start the session in 5 minutes. We are going to start the session in 2 minutes.
Good afternoon, everyone. My name is Paris Hadji, and I'm the Sales Director for Luminous Vision. On behalf of Luminous and our panelists, we welcome you to episode 1 of the Dry Eye Forum, a space dedicated to everything dry eye. We're very excited tonight to introduce to you our panel of experts. Dr. Sergio Solarino is the head consultant of San Antonio Private Clinic, Tomasini Private Hospital, and Policlinico Città di Quartu. He's also the CEO, founder, and managing director of Centro Vista in Cagliari. Dr. Samir Hamada is a consultant ophthalmic surgeon in the corneoplastic unit and eye bank at Queen Victoria Hospital and director of the London Eye Clinic. He's also our moderator in tonight's discussion. Unfortunately, our third panelist, Professor Stephen, will not attend due to a last-minute unforeseen engagement, but we have a very pleasant surprise. Dr. Conan Tam of Burnett, Hod, and Tam Optometrists will give us a unique view from an optometrist perspective of the issues at hand. Dr. Tam is running a very successful practice and one of the very first dry eye clinics in the London area. So, without further ado, I give the floor to Dr. Samir Hamada.
Hello and good afternoon, everyone. Right, I'm really privileged and glad to have two of the I would say the best people to talk about dry eye. People who have dedicated a lot of their time and efforts in managing patients with dry eye, and we've got Sergio Celerino, who's known in the field from Italy, and we got Conan Tam, who's a senior optometrist, specialist optometrist actually, with a focus on dry eye disease. And I have to say that Conan was one of the first who really adopted or started dry eye practice in London, probably one of the earliest. I'm not sure the first, but one of the earliest dry eye clinic in UK, which is amazing, just to show his interest and willingness to help the patients. So without further delay, we want to start, and we have a lot to discuss today. What I'll try to do, I'll try to kind of summarize the key main areas we're going to cover. We want to talk a little bit about awareness of dry eye. And this is not just about the physician awareness, it's about also the patients. Because I think that will help us to understand where we stand and how can we deliver a better service and better treatment to our patients. And next, we're going to talk a little bit about some treatment options. And again, we're not going to dive deep in the management option. We want just to get a bit of experience, share some of our honorable speakers today, their experience in the field and what they do in management of the patient with dry eye. And we finish about what the best way to establish let's call it successful dry eye practice. So welcome both, and can I just start to say you're probably aware that the awareness of dry eye has probably increased, but maybe not to satisfactory level what we wish, because I'm sure, like myself, we often struggle to find, let's call it ears, to help us in managing those patients who I find sometimes they need help more than myself. They need their GP, their optometrist, the social care to help those patients who kind of can be suffering with a disease that it can be very refractory to treat and manage. I just want to share this slide, which will help us a little bit to go through the points we'll discuss today. So if I do that, okay. So really, when you talk about awareness, I mean, we know that the environmental change could be contributing to increase the prevalence of dry eye disease. So I'd like to call it a disease on the increase. And I don't know, I'll put this point, and I would like to hear your views, because my feeling here that actually there's many factors make this disease on the increase, not just because we doctor more interested in it now. I think there's genuinely environmental changes. Now we've seen children and men with the disease, with younger patients with disease, a disease that used to be labeled for middle-aged females. It's no longer the case. So there is probably climate change, the digital world we are in, the habits, the lifestyle, all sorts of there's more interest in obviously various sports which have a visual requirement, and different types of makeups can really affect the ocular surface. But also maybe to do with more diagnostics. Now we are clever in looking at the ocular surface and assessing meibomian glands, for example. Or is it because actually we are even smarter now in trying to find better treatments to address the dry eye disease, like IPLs, for example? Or is it the patients themselves now with this digital world where you have a lot of information on the net? So these patients are more educated, and they challenge you, and they want you to up the level of knowledge to meet their expectation. And don't forget, we all practice the refractive surgery and premium lenses, and there is no place for less perfect results with those patients. And when you have a dry eye and you're going to have a multifocal lens implant, that is not a good combination. Obviously, it will affect the results. So can I invite Sergio, if you want to show your thoughts on these points, please?
Yeah, sure. I think you are completely right. It's very, very important, the actual situation. And I think that in a similar way to myopia epidemia that you know is affecting actually the major part of our very young students, because we are expecting in the next years to have an increase in myopia patients, young patients. The same thing is happening to dry eye disease in patients, because even though in the last 10 years we were used to see all the people with dry eye, or people with, that have in use a large quantity of medications with the dry eye, actually we see that also the young boys have frequently the dry eye, and this is perfectly correlated to the stress that the new digital strain that we see in those patients. They live with the phone, with cellular phone in the hand. They do play the PlayStation or other games continuously. So everything is entering our actual situation of knowledge from the eye. So is enlarging this epidemiological quantity of people. I think also that the awareness is increasing, because the media actually are more frequently talking about the dry eye. But as you know, the web is not the right solution, because sometimes you can find the very correct solution for the dry eye diagnostic or treatment or opinions about the dry eye that are corrected, but sometimes you find everything. So it's very difficult to make those people understand which is correct, which is not. So I think we must be more frequently on the TV, more frequently make a good quality advertising on the dry eye, more frequently on the newspapers or magazine, talking about the dry eye. And I think it's very important the correct diagnostic set for this, because treatment is something that comes later, but we must test, I think, all the people that comes from for a surgery, even is a surgery for cataracts. You talked about the premium lenses. We need a good result. So you are completely right. The awareness must be increased.
Mm-hmm. Yeah. So, well, Conan, if you think about, like, as a specialist now, we had a dues report first one, and then the second dues report, and now obviously we're having a lot of cases the last year since the COVID, where patients wearing masks, a lot of patients who are borderline now, they're manifesting the disease. So I think as a specialist, we probably have a lot of like noise about dry eye, so we are more aware of it. But from your point of view, from where you are, do you feel that that knowledge is enough and awareness about dry eye among ophthalmologists and optometrists is enough? And if not, what do you think we need to do maybe to improve that?
Yeah, I mean, we are certainly seeing more dry eye awareness among the professionals. There is still just a lot of different avenues to explore. I mean, I think the really important advice is to raise awareness in the younger populations. I know a lot of people who get in touch are finding their own ways to explore Facebook and other social media ways to find information about dry eyes, but those are the problematic ones. It's easy to find if you have the issues, but for the more asymptomatic people, I think it's the awareness of school-age children. It is a bit of a ticking time bomb with all these kids doing a lot of lessons online, especially during COVID. A lot more screen time, as you said, Sergio. And you know, they need to be aware of what the dry eye signs are and rules to stick to minimize the onset of dry eyes.
Okay, I mean, Conan, do you feel like sometimes I think there is a lot of dry eye forums online, basically, right, for the dry eye patients. I'm talking about patients now, and sometimes I find the patients get really confused and overloaded with this information they found on the net. And unfortunately, a lot of this information comes from people who are maybe just dry eye sufferer. They try to explore everything and they share their own experience.
Yeah.
Sometimes it's a lot of misleading information. And I feel sometimes also there is a bit of overlap between allergic eye disease, digital eye strain, not necessarily just a dry eye. And it's I'm not saying there is a magical bulb and a solution for that, but how do you deal with that? I mean, what do you tell your patient when they come and they say, well, we read this on the forum and we've done this, and it's quite challenging. Do you investigate there is a way to make the knowledge better than misleading knowledge sometimes?
It is really difficult. I mean, these patients, especially the really problematic ones, are so frustrated. They are willing to try everything. And what I would say to most of them is that, you know, your dry eye is not the same as everyone else's dry eye. So one thing might work for someone else, but you know, it's not guaranteed to work for you. So don't go trying everything that's on there. There are some, as you know, some drops and some homemade drops that patients talk about, which somehow may work for one person, but it's not really designed for eye use and may cause some problems. So a better, you know, online presence from all professionals detailing the recommended treatments and the need to have a proper you know, assessment done before embarking on any of the treatment options, and that's the most important thing. You know,
I agree with that.
The patients, a lot of them come with their own perceived diagnosis already. They think that they've got this certain thing, but it hasn't been looked at. You know, they followed all the symptoms that everyone else has got on these forums.
Sure. Yeah, I agree. I think probably the best way is to get the information from the right sources, which are us, optometrists, ophthalmologists, organizations, spread the knowledge rather than hear it from the public. I think that's the best way to deliver knowledge. And I think I like what Sergio said about we see patients from various conditions. You got patient coming for cataract surgery. They're coming in my waiting room. They said, but we have the information. We have a leaflet in the waiting room. We have the magazine, OSI magazine, example. They read about dry eye. Actually, they're kind of educated while they're sitting. And this patient not coming for dry eye. They're coming for cataract or LASIK, for example. But suddenly actually they're more, and they can tell their friends and relatives and all that. That's right. So can I ask you, Sergio, so what do you think about the physicians, the ophthalmologists and optometrists? Do you think we are interested enough and have the knowledge enough about dry eye, or you might be sometimes don't see that picture?
I think that the interest is increasing actually because you know, the buzz is a big volume actually increasing. So everyone understand that there is something new about the dry eye. They want to know something, but actually most of them is skeptical about the treatment. They don't know exactly which is the physiological mechanism of the IPL. So it's sometimes difficult to make them understand. It's more easy for the patients because the patient is coming in need of knowing something new. So they read something, they saw a television with a ophthalmologist or optician talking about this, and they are very interested in resolving their situation. So the most important thing I think is to talk with the patient. The basic in my clinic actually is made them aware that there is a problem. The problem is a wide graduation of severity. We don't know exactly which is the severity of that patient. after the examination, we can see where is his own situation, and I talk with them, because this is the initial talk, and I think that is the initial transfer of information from us to them. If we put some time in this, we will have many satisfaction in back in the next months. So I think it's very important to stop with the patient. We usually have a sheet like this with all the examination that we analyze one for one. We explain which is their own objective situation. In that, the patient understands that he has a problem, the severity of his problem, and that there is also the possibility to compare after 2 months, 3 months, the situation if it's changing something, because not all the patients feel directly as well if something is changing, but the examination is objective, so probably can help them to understand what is happening. I think it's very important, the initial talk.
Perfect. I mean, to be honest, you answered the question where I was to ask about compliance, because I think one of the challenging issue with patients is the compliance. I mean, I'm sure you both agree with me. This is really difficult. I mean, putting so many drops, coming to a treatment, and patients sometimes impatient, they want quick results, which is actually not always the case, right? So so I agree with you. This kind of material you show the patient, you show them, you explain about their disease, what is it exactly, so that knowledge. You show them the mammography or the tear break-up time. You showed us just to say, this is where you are, this is how we improve. I think the visual material you're giving to the patient definitely help. I mean, when I show my patient the mammography images, this is your gland. Trust me, this is the one thing that makes them suddenly switch on. They want the treatment. When they look at, oh my God, am I losing those glands? Are there 2 missing? And I know 2 glands missing is not a big thing, but I like to show that because I know that will make them compliant with the treatment. And I think that's a very important thing in terms of, and I tend to explain to the patient about the medication, as you said as well. Look, this is what for, and this is what we try to do. So engage them more in the treatment. They take responsorship and ownership of what they're doing to help themselves, rather than everything on us, basically. And they just come to you and say, I'm not better, can you help me, etc. So yes, actually that gives us a move to the next point, which is, how do patients end up in surgeon's clinic or end up with Conan clinic? I mean, can we have like start with Italy to see what the model, where the patient come from? If someone feel like their eye not right, they're dry, do they come straight to you, or there's like a pathway? What the modes of or models here?
Well, if I can speak first, I can answer you that in my clinic, people comes mainly for surgery. So we have 20,000 passages of patients during the year, and from them we collected all the people that need sometimes surgery for the cataract, sometimes for refractive surgery, for glaucoma, and you know, all the things that we can detect during the first visit. But actually, there is no so much people that come directly for dry eye. I think is a minor part. Actually, we are advertising for the dry eye also on TV, and this is making the people in my city, in my town, aware that there is a place where they can go to understand better their disease and probably to treat the disease. I think it's very important also to talk to all the other physicians, but not only the physicians that are rheumatologists, neurologists, or other people with other specialization, dermatologists, but also it's very important to talk with the people that work with you, because sometimes we do different things inside the same place. So there is people that like very much to follow people with glaucoma, and we must talk about the glaucoma therapy and what we can do for better compliance of the therapy. And so we must insert the dry eye disease concept, the treatment of dry eye disease concept in every one of all the people that is collaborating with us. Then we can also move towards the pharmacists, the other specialists. But the first things to do, I think, is to discuss with all our collaborators how we are going to treat those patients.
Excellent. Conan, can you tell the audience about the UK pathways?
Yeah,
how
so
yeah.
I think my practice is very different to yours. You know, we're non-surgical. I think a smaller percentage of my patients come through our main optometric clinic. So it's ones that we pick up who've been in contact lenses long term or just age-related dry eyes. The majority of our patients coming into the dry eye center are people who have searched for us online. So these are dry eye sufferers who have been online forever searching, you know, for different solutions. So often, you know, we have some who come in for an assessment for the very first time, but we have many who also have been bouncing around different places. I'm sure I've got some patients who have seen you, Samir, and then vice versa. They kind of bounce around. So yeah, it's a very interesting mix of patients, but I would say most of them come through Google search, online awareness. Most of them come through that way, and forums as well. So they really talk about different. I tend not to get involved with that and look into these forums, but there is a lot of chat about different people treating this, and I'd say yeah, a huge amount of them come from these discussions.
I mean, yeah, that's very helpful, because that tells us that then if you know that there is that section of patients coming through the net, through the research engines, so obviously that's where a lot of information, some are good, some are not so good. So really more information resources from us as a specialist, I think will be very useful, which I think we're doing, but also us talking to various groups, like I do patient seminars, for example. I talk to various organizations and charities. This is increase the knowledge about various topics, including dry eye. So that's the net one thing. Two, which as you said, the optometrists, some of them refer to us as well. They I don't know, do you have optometrists in Italy, Sergio? Do they have
in Italy, we do not have such quality of professionals, but we have something that is in middle, because we have assistenti di oftalmologia, that is a degree that permitted those people to work with us for helping us in everything, but actually not to work alone, standing alone, because they are a complementary figure. And we work a lot with them in our clinic. We have 4, and they help us very much for all the things, for not the treatment, because they can't treat the patients, but all the diagnostic part is actually held by them.
Yeah. So so basically we have the optometrist, which is a huge body basically of specialists in and they're almost everywhere. There's I don't know how many times of the number of doctors of ophthalmologists, but certainly a lot of them develop interest in dry eye. But what I mean here is just when the patient have a problem with their eyes, they think it's dry, either they go to pharmacy, so they ask for some drops over the counter or help from pharmacists, or they go to their optometrist. And then I'm glad that, for example, in the UK, to be honest, most optometrists now familiar with dry eye. They know what's all about. They know that's where the patient needs to be referred, and that's very important. And that thanks to the various like organizations, the College of Optometry or whatever organization, they arrange all these webinars, education, CET seminars, etc. That all helps spread the awareness about dry eye. But then also you got the GPs. We have a general practitioners in the UK where patients actually go to ask their doctor to have some drops for dry eye, etc. And some of GPs actually, or actually maybe a lot of GPs, not really know much about the dry eyes, and for them can be a very simple thing. Okay, take some drops and that's it. But patient end up frustrated. They want more, and then the GP reluctant to refer them to NHS because NHS is flooded with various other more complex conditions as they see it. So here where we actually found educating those group of people, so go speak to GPs in various occasions, all healthcare professionals, basically, not just GPs, definitely will help. So that is definitely various ways to increase awareness. So I think it's a mixture of everything, isn't it? And it's a combination effort from all of us around it. And don't forget, we all goes to those international meetings, and dry eye to be like 2 lectures in the whole 3 days meeting conference. Now almost every hour or 2 there is a talk about dry eye and treatment and diagnosis and all that. So it's good. Okay, so let's move to next item, which is about those patients coming for kind of refractive surgery, right? And Conan, you might not see those before, or they might be coming to you, say, as a surgical way to get rid of glasses. Sergio, probably you see a lot of them in your practice. Those patients, I see them as well. They're coming for laser vision correction, for premium lenses. And we know how much the tear film stability affect their outcome and results. And I think the 2 most upsetting results for patient is one, fluctuation in the vision after the surgery, which is usually because dry eye, especially LASIK, for example. And the second one is the residual astigmatism, which is, we're not talking about it now, but again, even the astigmatism measurement, the keratometry readings can be wrong if you have a dry eye and you try to measure the ocular surface. So you end up by thinking, actually, most of the issues or problems to patients after premium lenses or after refractive laser surgery is to do with dry as well. And that's why if I start saying, in my practice, almost all patients going for laser, PRK, or refractive lens surgery exchange or premium lenses, we assess their dry eye, we treat them, even if they have a very mild form dry eye. They all asked to do the MGD management, the flaxseed oil supplement or omega-3 supplement, etc. So we prepare them, and in my experience, it makes a huge difference to those patients. What's your views and experience with that?
So I agree totally with you, because there are 2 phases for the dry eye patients that are going to underwent a treatment, surgery for cataract or for refractive surgery, because all the examination can be really different with a good lacrimal film or not. Even the evaluation for the intraocular lens can be very different. So first we put very attention to educate optometrists that work with us. That the figure that I talked about a few minutes ago, the assistente di oftalmologia, that in Italy is the correct professional, to put some drops before each examination, just to have a better understanding of the real corneal parameters before surgery. But apart from this, we also actually made everybody must be evaluated for the dry eye with a complete evaluation. We talked with the patient, and at first we tried to make a long period treatment for the dry eye with IPL, and we saw that mainly the LASIK patients, but also premium lenses patients do not prefer to treat before the surgery. So we actually do like this. We do the examination, we discuss the situation with the patient, we do 1 or maybe at maximum 2 treatments before the surgery, but we make them understand that they will continue treatments after the surgery for 3-4 months, if possible, with IPL, because is in need for getting the better results, not only for the comfort, but also for the visual acuity. Is experience of all of us that made some refractive surgery. The patient is not seeing so well. we put some drops, immediately they see 10 on 10. So the importance of the drops that we put is what we are explaining to patient. If they can have a good surface, a good situation for the surface with no more dry eye disease, they can see well, they can reach a better situation with the visual acuity. So I think this is very important.
Actually, Sergio, I hope you don't mind me, but because you're saying is you said a lot of amazing, important information quickly, and I would like to go back a little bit. So patient coming for you for LASIK surgery or refractive lens exchange, etc. So you do their dry eye assessments, right? So you do questionnaire, you said. So this is what actually, just for the benefit of the audience, when these two reports say the how to diagnose dry eye, you need a definitely questionnaire. So you need subjective assessment. So that's a questionnaire. And then you need to do one of the three parameters, which is the staining, ocular staining, the osmolarity, or the tear break-up time. So you do those, right? But when do you decide this patient actually can go straight to refractive surgery, or no, I need to treat them? And from those, who are the ones that you go say, okay, actually I want to do IPL, because you said some of them you do IPL start before the surgery. So very interested to know all these details, if that's okay.
Okay, as you know, when we test people for dry eye, we can have a very wide variety of situation, but we can say that the major part is evaporative situation, because we know that usually the hyposecretive situation is for old people that has mainly other problems like rheumatological problems. They are more hospital people than normal surgery people. So I think that in those cases we can discuss with the patient. I make you see this is the examination, but the examination has all the things, because we have obviously the non-invasive break-up time test, that is something that is explaining the people that they have a pathological resistance of the lipid layer, so we can improve that. Probably this is enough for getting the operation. So if we have mainly those situations, we can improve with the IPL, so we can test the patient, made the IPL, then do the surgery, they continue the IPL and retest the patient. And we have a situation that is better than before, that we were operating people with cataracts without a test for dry eye and without any other IPL system to apply to them. So actually it's very different, I think.
How soon you do the IPL before the surgery? So you do it, then you give them a gap for what? Days,
yes,
weeks?
we do the IPL, the first treatment, then 15 days apart from this, we can do a second one, and then after the second one, we leave about 2 or 3 weeks to have the operation, the surgery.
Excellent.
And then we wait about 3-4 weeks for have the new treatment, the new IPL treatment again.
Excellent, excellent.
Can I ask you both, you know, doing IPL treatment leading up to surgery, do you treat them with drops as well, medically, alongside IPL?
Usually not before the test, because we want to have a naked test without anything on, no drops, no cortisone, no other things that can change the test in a way that we want to know exactly which is the situation. Then obviously for the surgery, we treat the patient with some drops. For the surgery, usually we do use for the cataract surgery after that an association, antibiotic cortisonic association for about 2 weeks. and also drops. I mean lacrimal substitute, different brands, but to help people for the dryness. And obviously, the thing is changing after the surgery. You know, also for the surgery for the cataract, we use povidone iodine for about 3 minutes before the surgery. So it's a trauma for the conjunctiva, for the cornea too. So there are many things that work against the surface, and other things that can work for the surface, like the IPL and all the other treatments. Yeah. We usually add in the first treatment EPL, maybe in the third, we add the meibomium expression with very we express each gland in the lower and the upper eyelid, because I think that this help to start the clearance of the gland and to start better, to have better results more faster than we were used not to do that.
Sure. So what I do in my practice is a patient coming for any form of premium vision correction, let's call it LASIK, PRK, RLE, etc. I do dry assessments, similar exactly what you do. So we have all diagnostics. If the eye dry, and especially if they have a staining on the cornea, on conjunctiva, this is a sign for me of a damage, ocular surface damage. So if a little bit of T-break uptime can be enhanced, I know they're gonna get better. If they have a staining on the ocular surface, it's not a good sign. This is mean that they need a bit longer treatment. And I think those probably are those ones I will offer them IPL if it's to do with MG, the issue here. So basically, let's say a patient come, they're not suitable. I'll tell them, you're not ready yet. I'll give you 6 weeks management of MGD package, heated mask, massage, omega-3 supplement, some artificial drops. And I'm not really fussy about the artificial T drops because I know they lubricate, but they don't really treat. And they come after 6 weeks. We do dry assessment again. If they're better, then that's fine, given the sign off for the surgery. If not, I'll treat them with a cyclosporin plus minus the IPL for another 3 months, and then I'll see them in 3 months. If they are really better, that's it, they're ready for go for surgery. And I have to say, with this regime we've been doing for a long time, I really rarely I have a patient come back and they're really bothered with their dry eye after surgery, because I'm stronger believer that actually if you improve the microenvironment, the homeostasis of the ocular surface in the first 2 weeks after surgery, which was we do with the preparation before surgery, they really heal so well, and the corneal nerves heal regenerate so well after LASIK, for example, or PRK, and they don't really have a long-term dry eye issues. So I think that will make a difference to those patients for sure. So
that's really interesting, because
it's really interesting.
I was just going to say, because we have patients who we see post-refractive, and it's difficult to know whether there was pre-existing dry eye issues that weren't solved before surgery or as a result of the surgical process. So it'd be very interesting to see, the treatment before all these refractive procedures.
Absolutely. Okay.
Sorry.
Go ahead, Sergio.
If I can add something, I must stress one idea, that is that sometimes people that need a refractive surgery wear contact lenses, and without the lenses they have some form of puntata on the cornea, keratitis puntata, because the lens is a protective protecting the surface of the cornea, even though if they don't feel anything with the lenses, if you stop the lenses, sometimes you find that they have a very poor situation for the surface. So you must understand that something can be pre-existing of the surgery, and we must try to understand if they have really that staining of the cornea that Dr. Samer Hamada was saying about.
Good.
I really
okay. with the remaining time, I just want to quickly go through things, because we talk about treatment now, actually, which is nice that the discussion naturally developed into those stages. I didn't have to do much here. Just one, when you talk about treatment, so really, sometimes we ask a very simple question, and really very true question, and that sometimes come from someone very not interested in dry eye. Say, Dr. Hamada, do we see any change in treating dry eye to improve patient expectations? In other words, have you done anything big different in the last few years to improve the expectation or the help those patients with dry eye? And sometimes I think much and I say, well, I don't think much more than maybe light therapy, IPL, for example, maybe using more biologic, but I don't think that's improved hugely for the last. So we're still around these couple of options, to be honest. I don't know what's your experience, both Conan and Sergio.
Sorry, do you mean the other treatments that are available?
Yeah, so if someone asks you what happened in the last 10 years, what are your powerful tools to treat those patients with dry eye? Especially if someone come to you, those dry eye patients, I mean, a lot of them, as we said, they're not really patient. They want something. Give me the stuff that works. Don't just take me and back forth to clinic because I want something works. I need results. That's what happened. So do you feel you are in that position where actually I have those tools to give you that cure? Let's call it.
I think you're right. It is. Sorry. IPL is the most advanced treatment that we have so far, especially in the last 10 years. I mean, obviously we have advancements in medication like cyclosporin. Actually, cyclosporin's been around for more than 10 years, isn't it? But different formulations, that has certainly helped. We're still waiting for other ones like Cedra to come on our shores. Apart from that, it is the IPL that seems to be the most advanced treatment, and the other one for more severe dry eye is our contact lenses. So we've gone full circle and gone back round to fitting scleral lenses for the very severe ones, and in fact, more people with not so severe dry eye are asking now for scleral lenses as well.
Amazing. We should have a session talking about this, Conan, because I think it's a big area and there's a lot to talk about that. I agree with you. About you, Sergio?
I agree totally, because there is no something that can solve completely the dry eye in one touch. We know that the time in which dry eye develop is probably 10, 20 years for those people. They are on therapy from antihypertensive from 10 years or something like this. So they have a very long-standing causes that provocate the dry eye. So it's impossible to make them reverse the dry eye immediately in one single shot. So I think but that the drops usually are not very, they are not so, the compliance about the drops is not so correct as we think. We saw that about glaucoma, that is so terrific in results where they do not use the drops. We can imagine that also for the dry eye that is less dramatic for the results. The compliance is poor as well for the drops. So the treatment with the IPL is something that is in few treatment days, because it's true that they have to come month after month in our room, but it's also true that in one shot we can treat all the surface. We can express the meibomian gland. We can clean the surface of the border of of the eye, so we can clean and make those people feel better when they go home. Usually those people sometimes text us that in 2 days I'm feeling really better. Is obviously we have to treat them many times, but is so long the period that they became a dry eye patient that obviously we can reach the root in any single shot.
Yeah.
We must explain this to patients. They understand usually.
Yeah. So
just say that it's a good point.
Carry on, Conan. I'm listening to you.
I was just saying it's a good point about the lid cleansing, which I didn't think about, but that, you know, we obviously have always advised proper lid cleaning, but it's the techniques that have improved. You know, you've got the BlephX and the different wipes that we have. I know the thought about tea tree is a little bit unknown at the moment, but yeah, I think if you speak to most patients, they are much more clued up about lid cleaning than they were ever before. These lots and lots of products are now available, which are really useful, especially for those with the classic anterior blepharitis.
I agree with you, and to be honest, I think definitely we need another session talk about evidence, what works, what does not in dry eye management, and go more detailed in IPL, because as we know now, IPL is just not more just about MGD. There's a lot of application now treating the chalazion, obviously future rejuvenation, thermal treatment, acne, all that. So we could talk hours about that. But just interested here why we was talking about it. So when you give your patient IPL treatment, and I'll listen to you, then I'll share my experience. When you tell the patient, okay, here we go, done your 3-4 sessions IPL, what do you tell the patient to change? Do you expect them to still using drops and doing hot compresses and massage and taking supplement, or do you tell them that, which what the patient want to hear, that thank you so much, that's it, end of the world, and I'll come back next year to have maybe a top-up session? What do you tell them? What do you advise them about what's the management after IPL?
Well, I think that we always must talk with the patient that the things are changing slowly, so they are not supposed to expect the things change in one day. So they have to put very attention to their lid margin, to clean the margin, to put the drops. And one of the things that I think is very important is the approach to the home or the workplace, because those people usually don't have enough humidity when they do use the computer, sometimes for 8 to 10 hours a day, and they don't put the drops because forget to do that when they apply to something reading for a long time. And I explained to those people that the blinking lower is very rarefact, because one on 10 times than during normal life, if you have a very attention to text in your computer or in your cellular phone. So you have to change many things that are something about the eye, cleaning the eye, the lid margin, putting the drops, something about the way they live. So remember to have a stop, to close their eyes more frequently, and then use also sometimes humidification apparel that can help them to stay longer at the computer if they work with the computer. I think this is enough important to reach our goal.
I agree. I mean, I always tell the patients this is, it's not going to be fixed forever. It's a lifelong condition. So you do have to maintain your eyes, and the more you can, you got to be careful, because some patients do compressing 3 or 4 times a day, or lid clean about 3 or 4 times a day. So I think you have to educate them about winding that down and just doing more of a maintenance rather than overkill. And also, you know, it's important to keep up those things to reduce those triggers of inflammation. You've treated the inflammation to a certain level with IPL, and you want to reduce those factors coming in again. So it's those things of, you know, keeping the glands flowing, keeping the lashes nice and clear, blinking in front of the screen, so don't just stare and do hours on end in front of a screen, and things like you said, you know, increase the humidity. So all very, you know, obvious things to us, but these things need to be reminded to the patients to keep going. Otherwise, you'll be back sooner for IPL.
This is very true, Conan. Things looks obvious to us, might not be for the patients, which is very true, the situation here. Okay, so we're running out of time. I just want to finish because we promised to cover this as well. We do it just in a couple of minutes. I'll say this about how to build a successful dry eye practice. And this is not far from increasing awareness, because obviously we have our duty, educate patient, educating colleagues and other healthcare help associate about the dry eye. But I think, and this is my view, but please your suggestions later on. So to establish a successful dry eye, actually, one, you want to make it known to others. So as you said, Conan and Sergio, patients search for you, they come to you, so they know you. So you are known to the other ophthalmologists, to the patients, to other colleagues, etc. So they refer to you. I think we have to agree that if you want a dry eye clinic, you need some specialist kits, but I'm gonna throw a comment later on about that. But I think as a dry eye specialist, you need a bit something like to help you to improve compliance, something like the meibography and show them the tear break-up time and non-invasive tear meniscus height and over time, just something visual to help you improve compliance. And I think knowing your role as you are the head of the team, but also what's your team role as well. Because I think not all of us sitting doing the IPL ourselves. We have a big team. Obviously, we have the technician, we have the optometrist, we have technicians and assistants, therapists. They all a part team, and they all need to be involved, knowing what this pathway in managing dry eye disease. And we discussed where IPL fit in our practice. And I think I'm one of the people who are. I'm being very conservative offering IPL to patients initially. And I remember years back where I was like really strict about not offering light therapy until I have exhausted all the other modalities. But with time, with experience, you learn actually there is a lot of modalities now to be coming out of outdated and really doesn't make difference to patients. And now I'm really more kind of offering IPL at early stage during the treatment, because I think we have to think differently nowadays and meet patients' expectation. And always my theme saying about increasing awareness. So the AEC to me is awareness by education to increase compliance, and that seems to work very well. Do you have anything else to add, Conan or Sergio, to advise people who want to start or establish a dry eye practice?
I completely agree with the visual aids. A lot of patients who come, they've never seen what their glands are actually like. So they assume they've got meibomian gland dysfunction, but they don't know the severity. So as soon as they see, you know, the anatomy of their glands, they really understand a lot more about their own dry eyes. The other thing that I really like to show them, which is part of the diagnostic part of testing, is the expression. So when they actually see what comes out of these glands, that most of them are very shocked to and actually believe what you mean about the state of their glands. Exactly. So compliance really improves when they see what their glands are doing.
Excellent.
Yes,
okay.
I do agree with this because a patient really want to know how it works. They at first don't understand why we treat a part that is relatively far from the eye and it works on the eye. So we must explain how this works, which is the physiology of this treatment, and they are very curious about this, and they get the information, the precious information, because nobody talk about those mechanisms so usually on the newspapers or in TV. So we must focus on these and make them understand that we are treating, and we are in a car that was going towards a wall and trying to stop and go back when the car started. So it's a long way, and we have to weigh together, and every step is a good step in back. So I try to say this to my patients.
Excellent, excellent. So I have to say, we could talk longer and longer, and I'm really, this is an interesting discussion. But I hope we covered as much as we can about awareness, because I think everything we talked about, helping just driving the patient in the right direction, get better compliance, giving better treatment, and end up with happy, satisfied patient. That's what we want, really, to be honest. And we have just evidence that people listen to you and they like to listen to you, that our audience keep growing despite we passed the hour almost, about the hour. Usually when we start to reduce, we are increasing, which is very positive. So well done. Now we just finished with some questions, because it's not fair people throw their questions. And I see who the team who gonna, is Beatrice here? She gonna ask the question, if it's okay, please, Beatrice.
Yes, I'm here. We have received some questions from the attendees. So the first one is about LipiFlow and M22. Which one offers best treatment and why?
Okay. Shall I say first? Right. So well, I've been kind of privileged to try various treatments. A lot of companies happy to give me some of the trial periods of various devices. And I have to say, I tell the patients there is a difference between heated treatment, which is LipiFlow, MevoFlow, even heating the mask massage, whatever, steam, steam, all these are heated treatment and expressing the gland, between addressing the dysfunction of the gland, which is the key thing here. IPL is not just about heat treatment. Yes, a heat pad is heating the skin is one of the modalities, but it's not the whole thing. Otherwise, you won't have the result that lasts for long. And my personal experience answering that question, the outcomes of LipiFlow is not really different from MevoFlow, which is like a couple of months, 3 months improvement, but that's it. There is no long-term stability of tear film. And I obviously, if the patient have asked for which treatment to go for, I definitely will say IPL. There's no question about it. It's addressing the dysfunction of the glands. That's what we want. And I have a lot of examples where actually I could see the meibography improving after the IPL. I can't say I've seen the same after LipiFlow, MevoFlow, all other modalities. What do you think, Sergio and Connor?
I think exactly the same, because we can express the meibomian gland in many ways. This is an automatic, complicated way to express the gland. We do the same manually, very carefully, after the first treatment and the second or maybe the third treatment with the IPL. But you know, the most important thing is that IPL actually is working to the root of the problem, because it is trying to resolve inflammation that is making the meibomian gland dysfunction. So it's a radical way that we haven't in the previous era against the meibomian gland. Obviously, hitting the lid, expressing the glands, everything is of the same plane, resolving and activating the clearance temporarily, but we want something more, and we are actually obtaining something more with the IPL treatment, because it's a completely different pathway that is against the inflammation, that is entrapping actually the meibomian gland.
Yep. Conan?
I completely agree. I mean, I haven't got any experience with the LipiFlow. The only thing I would say is that going back to the manual expression, is you get really important information from squeezing the glands manually, and actually, for me, that's a really good way of assessing the improvement of the patient. So not just looking at the mybography, it's doing the squeezing every time to see the consistency of the mybum coming out.
Sure.
Exactly. Okay, next question, please.
Next question is, can you use IPL in patients with acne rosacea?
Sergio, you want to take
Yes,
that?
of course. Rosacea is the main target for IPL, and obviously you must treat those patients. And probably is the best dermatological situation to have a result and make those people better in their meibomian gland dysfunction. So is the main target for IPL. Obviously, also people that don't have a rosacea, a very important rosacea, something less than a pretty conclaimed rosacea can be treated with a good result, I think.
Yeah, and that's following to that, Sergio. I agree with the. To be honest, allude to what Conan was saying as well. Part of the assessment and deciding the treatment is the functional, when you express the glands and various points across the eyelid, and to see what meibum grade is it. If it's obstructed, if the glands don't exist or not, number one thing, and if it's grade 2, 3, then you need just to improve the function. And the observation about, is it rosacea refractive or is different type of MGD, that will actually make difference between some patients respond so well to IPL, almost 100%, and some patients actually maybe not. So that is actually, but a lot of times if you look back, you find actually the indication was not perfect, and I will never set expectation patients saying it's 100% going to work for you. If the rosacea, I say with confidence, it's going to help you. If it's less different type, I would say 60-70%, depends on the condition. Good. More questions, Beatrice?
Yes, they are asking is it possible to make and combine blephastim plus gland expression plus IPL in the 3 or 4 session in that order? So blephastim plus gland expression plus IPL.
What do you do, Conan?
I do either. Well, I don't do them together. I tend to use heated expression for those who are not suitable for IPL. For the IPL ones, I think, you know, that byproduct of heat from the IPL is enough to do the squeezing alone, and I don't feel the need to do the blephastim on top of that as well.
Good. Anything to add, Sergio? You okay?
I do agree totally with what Conan said, because is a correct thought about those different things. Yeah, sure. I agree.
Okay. Any more, Beatrice? I'm not sure about the timing. We don't want to exceed the timing.
Yeah, we have some more questions. So maybe we go ahead with 2 more questions, and if you agree, I can send you an email with all the questions that we are still having, and send back to our attendees.
Okay, yeah.
What are the contraindications for IPL?
Okay.
I think the first thing is
IPL. Go ahead, Conan.
You go for it. Well, I was just going to say the first thing is skin tone. I would say it's the most important factor to think about. Obviously, with the device, that, you know, the Luminous device, we've been able to expand a little bit more, but you've still got to be really careful with skin tone. Even, you know, tanning as well. You have to ask about a patient's lifestyle. What have they got planned in the next few months when you're trying to plan a you know, sequence of IPL? What do you guys think? Do you agree on that?
Yeah, I agree. I think also that some dermatological heavy condition like lupus, like psoriasis, do not fit for a comfortable treatment for IPL. There is no complete agreement all around the world about psoriasis, but actually there is no indication for those patients to be treated, even because they are frequently treated with medicaments with that has enhanced the sensibility of the skin to the light. So we must be very, very careful in those patients. Also patients that are on therapy with treatments that enhance the light sensitive response to the IPL. So it's very important to understand this. I ask those people if they have some condition like this. And I suggest also to ask very firmly to the young ladies if they have something on the face, because actually you say, do you have anything on? No, I didn't. Nothing hydrating your skin? Oh yes, I put every morning that, and so on. You can discover that they have many things on their face, and we must have a clean face to treat those patients, you know.
Of course, yeah. Obviously, we can go. There's a lot of things. I think we need really another episode for that. This is a lot to talk about it. But I add to what you said just quickly. The general health, very important. I see what they take in medication, and yeah, I agree with you about type of skin, etc. And I have one or two cases where patient came back and they said they have a swelling on the eyelids, and that's actually an interesting question to ask you. Do you think it's make those patients will have fillers around the eyelids? Do you think they have some different reactions?
Well,
I haven't had any. Sorry, you go for it.
Go on, answer your first, please.
Well, I was just going to say I've not had any adverse reactions from it. I've been very nervous about doing some of these, and I've often asked them to wait longer. I mean, as you know, I have sought Dr. Toyce's opinion on this, and he said, yeah, wait a couple of weeks and it will be fine. And I you know, I haven't had any reactions, luckily. So yeah, over to you.
I think that is very difficult to understand what will happen in those cases, because the only thing that we really don't know is the level in the skin they put, they added the filler. So it's very difficult to understand this. So the effect can be every effect. We know that actually is growing also the attention for migrating fillers inside the orbit. We read about say blindness coming from these. So we have read more and more that the people are treated with fillers, the more we know adverse effect about this. But actually I haven't any effect treating a patient with filler with IPL. Actually.
Excellent. Nice to hear. By the way, just the patient who had a swelling around the eyelid and it was persistent, it did not clear. She was referred to her GP because we didn't find a reason, because I agree with you both. I don't remember any patient have any side effects, to be honest, to IPL. And that patient turned up to having a lymphatic disease. So it was actually the IPL helped to diagnose her condition, and she's on treatment. She's better now. So a diagnostic tool was it. All right. So Piotr, let's have the last question.
Yes. So this one is about what do you think about more natural approaches to MGD inflammation, like Manuka honey?
Oh, that's MGD talk today, right? So, well, if I say to be honest, difficult to answer the question quickly, but this is a whole thing about management, the inflammation, number one, and then dealing with the function itself and how to help the glands regenerate, etc. Well, Manuka honey as anti-inflammatory, I don't know, I don't have personal experience, to be honest, but I'm sure a lot of patients used it. Maybe that question comes from even a patient. Sometimes there's a lot of patients using it. I'm not sure if we have it in the UK as ophthalmic product.
it's not licensed in the UK, and I don't think it's even got CE mark to it. So most of the information I get is from the patients who've used it. It stings a lot. That's what I'd say.
Yeah.
But a couple of patients, you know, they swear by it. So.
Yeah. Okay.
Obviously, living in Sardinia, that is a very sunny place, we saw people that use the manuka honey for the sunburn, because the anti-inflammatory in sunburn is well known. So some people told me about this, but I never tried. I never had a patient that was using it for the dry eye disease. So I think generically it can be an anti-inflammatory treatment, but I don't know exactly the level of anti-inflammation we can get from this. And we know that we must express the glands. We can obtain something more radical for the vessels with IPL. So I think we are working with IPL at the root of the problem and not at the end of the inflammatory cascade.
Exactly. Well, thank you so much. There is just one question. I promise I will answer it. It is someone asked question before we come actually the meeting, emailed when they registered, they emailed a couple of questions. And I just want to be very brief, because it was what the tools you use to diagnose the dry eye disease, for example. Not everyone can have a meibography and all that. And I always say the two things. One is the 1-minute test, which is a strip of fluorescein, a drop of fluorescein in each eye. As a patient to blink, the first thing you look at tear meniscus height, you look at the tear break-up time. You can't do it twice. By that time, after 30-40 seconds, you have the staining of the cornea and the conjunctiva, and you're still looking at the blink rate as well. So in 1 minute, you gathered so much information. You don't need anything else, any complicated tool. That will not help you the compliance issue we talked about earlier, but definitely this is 1 minute test, give you the tear volume with the tear meniscus height, give you the tear film stability, break-up time, the staining, signs of damaged ocular surface, epithelial compromise, and stuffing off. So it gives you a lot of information. And then I touch the eyelid, like Conan would say, expressing those glands, see what's coming with them. Is it obstructive? Is it open? And what if it's open? What type of oil coming out of them? So, and that's maybe another half a minute. So 1.5 minutes, you sorted. Right. Okay, good. Thank you so much. I have to thank Lomni's to allow this very nice, enjoyable, and useful discussion today with very good colleagues here. And I hope we'll continue with that, because there's a lot we can discuss. And obviously, we try to cover awareness today as much as possible, with focus a little bit on treatment, change the patient's life and what works better. So thank you from me, and I'll pass back to the organizer, please.
Thank you very much, Samer. Thank you very much, Conan and Sergio. It has been a great forum. I just want to invite all the attendees to join us to the upcoming Dry Eye Forum. It will be episode 2. And we would like also especially to hear from them which topic they would like us to discuss. So if they have any suggestion, any topic that they would like to share with us, they can email us. I'm sharing here the email. Can you see it? I think so. Yeah. You can use the emia.vision@luminis.com to email us and say what would you like to discuss in the next episode of the Dry Eye Forum. And thank you very much again for your time and for your availability. We really enjoyed this session.
Okay. Thank you so much. Thank you.
Thank you very much.
Bye, Samer. Bye-bye, Conan.
Bye.
Bye. Thank you. Thanks to the audience.
Bye, please.